and a very warm welcome. I'm so glad you're here with me today. Have you ever wondered what happens to a medication after you swallow it? It doesn't just magically find its target and then disappear. Our bodies are incredibly intelligent and they have a sophisticated system for processing everything we put into them. This process is called biotransformation, or more simply, drug metabolism. It might sound complicated, but it's actually a beautiful and elegant process. Today, we're going to explore how your body acts as a master chemist, transforming medicines to use them, and most importantly, to get rid of them safely. So let's start with the most basic question: why does the body even need to do this? The primary goal of drug metabolism is surprisingly simple. It's to take drugs that are lipophilic, which is a scientific way of saying they are fat-soluble, and turn them into compounds that are hydrophilic or water-soluble. Think of it like this: oil and water don't mix. Many drugs are designed to be like oil so they can easily pass through the fatty membranes of our cells to get to where they need to go. But our main disposal system, the kidneys, works with water. It filters our blood and creates urine. If a drug stays in its oily, fat-soluble form, the kidneys can't grab onto it to flush it out. It would just get reabsorbed back into the bloodstream over and over again. So the body's mission is to chemically change that oily drug, making it water-soluble, so the kidneys can finally excrete it. It's a brilliant detoxification strategy. Now, this transformation process can have a few different outcomes for the drug itself. Most commonly, metabolism inactivates the drug. It takes an active medication and converts it into a less active or completely inactive form, essentially switching it off. But sometimes the opposite happens. The body can actually activate a drug. Some medications are designed as prodrugs, which means they are administered in an inactive form. It's our body's metabolism that has to flip the switch and turn them on to their active therapeutic form. And third, in some rare but important cases, metabolism can accidentally create toxic byproducts. A drug that is safe on its own can be converted into a harmful metabolite that can damage our cells. We'll look at a very famous example of this in just a little bit. To accomplish all of this, the body uses a fantastic two-step process which we call phase 1 and phase 2 metabolism. Imagine you have a piece of furniture you need to get rid of. In phase 1, you might attach a handle to it to make it easier to grab. Phase 1 reactions do something very similar to a drug molecule. They introduce or uncover a reactive handle, what chemists call a functional group. This is usually done through reactions like oxidation, reduction, or hydrolysis. The most famous and important machinery for phase 1 is a family of enzymes called the Cytochrome P450 system. We'll talk much more about them soon. After phase 1, the drug is a bit more water-soluble, but often it's not quite ready for removal. That's where phase 2 comes in. Now that the drug has a handle, phase 2 reactions attach a big, bulky, water-loving molecule to it. This process is called conjugation. It's like tying a giant water balloon to that handle. This makes the final compound very polar and very water-soluble, so it can be easily grabbed by the kidneys and escorted out of the body. So where does all this amazing chemistry happen? The main headquarters for drug metabolism is, without a doubt, the liver. The liver is a large organ packed with all the enzymes needed for these reactions. Because of its central role, the liver creates a phenomenon known as the first pass effect. When you swallow a pill, it's absorbed from your gastrointestinal tract and goes directly into a special blood vessel that takes it straight to the liver. This means the liver gets the first pass at metabolizing the drug before it ever reaches the rest of your body. For some drugs, this effect is so strong that a huge portion of the dose is wiped out on this first pass, which is why those drugs often have to be given in other ways, like through an injection, to bypass the liver. Now let's dive a little deeper into that superstar of phase 1 metabolism, the cytochrome P450 system, or CYP system for short. This is not just one enzyme but a whole family of them, and a very small number of these family members are responsible for metabolizing the vast majority of all medications. The undisputed champion is an enzyme called CYP450. It is responsible for metabolizing over 50% of all the drugs we use. It's an absolute workhorse. Then you have CYP2D6, which handles about 20 to 25% of drugs, including many common antidepressants and beta blockers. And there are others like CYP2C9 and CYP2C19 that are famous for metabolizing very important drugs like the blood thinner warfarin. We even have one CYP1A2 that metabolizes the caffeine in your morning coffee. So after the CYP enzymes do their work in phase 1, the drug often moves on to phase 2 for that final conjugation step. Phase 2 reactions are generally very fast. The most common one is called glucuronidation, where a molecule derived from glucose is attached to the drug. There's also sulfation, which attaches a sulfate group, and acetylation, which attaches an acetyl group. Another crucial one is glutathione conjugation, which is like the body's emergency response system for neutralizing particularly dangerous reactive molecules. Now here is where things get really fascinating from a clinical perspective. The activity of these enzymes, especially the CYP enzymes, is not set in stone. It can be changed by other things we consume. This can lead to very important drug-drug interactions through two main processes: induction and inhibition. Enzyme induction is when a substance causes your body to produce more of a certain enzyme. Think of it as speeding up the metabolic assembly line. A drug or even an herbal supplement like St. John's wort can act as an inducer. This means that any other drug metabolized by that same enzyme will be broken down much faster than usual. This can cause the drug's level in the blood to fall, potentially leading to therapeutic failure. The opposite of this is enzyme inhibition. This is when a substance blocks the activity of an enzyme, essentially hitting the pause button on the assembly line. A classic example is grapefruit juice, which is a potent inhibitor of CYP3A4. If you drink grapefruit juice while taking a drug metabolized by that enzyme, the drug won't get broken down as quickly. Its levels can build up in your body, leading to a much higher risk of toxicity and side effects. This interplay between induction and inhibition is one of the main reasons your doctor and pharmacist always want to know about every single medication, supplement, and even certain foods you consume. And what about when metabolism goes wrong and creates something toxic? The most well-known example of this is with acetaminophen, the active ingredient in Tylenol. At normal therapeutic doses, acetaminophen is perfectly safe. The body easily metabolizes it using those safe phase 2 conjugation pathways we talked about. But in an overdose, those main pathways get completely saturated. They can't keep up. So the excess acetaminophen is forced down a side path where a CYP enzyme converts it into a highly toxic metabolite called NAPK. Normally, our liver has a protective substance called glutathione that immediately neutralizes this toxic NAPK. But in an overdose, the glutathione stores run out. With no protector left, NAPK starts attacking and destroying liver cells, leading to severe liver failure. Thankfully, we have a wonderful antidote called N-acetylcysteine. It works by replenishing the liver's supply of glutathione, helping the body to once again neutralize the toxic NAPK and save the liver. Isn't that incredible? Finally, it's so important to understand that we are all unique, and that includes our metabolic machinery. This is a huge reason why different people can respond so differently to the same dose of the same drug. One of the biggest sources of this variability comes from our genes, a field we call pharmacogenetics. Tiny variations in the genes that code for our metabolic enzymes can have a huge impact. For example, with the enzyme CYP2D6, some people are poor metabolizers. They have little to no active enzyme. If they take the painkiller codeine, which is a prodrug, their body can't convert it into its active form, morphine. So for them, codeine provides no pain relief at all. On the other end of the spectrum are ultra-rapid metabolizers who have extra copies of the gene and incredibly high enzyme activity. If they take codeine, they convert it to morphine so rapidly that they are at a very high risk of a morphine overdose, even from a normal dose. This genetic variability is also critical for drugs like the blood thinner warfarin. People who are poor metabolizers of warfarin are extremely sensitive to it and need much lower doses to avoid dangerous bleeding. And it's not just our genes. Our age matters, as the very young and the elderly often have slower metabolism. Liver or heart disease can dramatically slow down how we clear drugs. Even our diet and environment, from charcoal broiled foods to cigarette smoke, can influence our metabolic enzymes. So you see, drug metabolism is this dynamic, complex, and deeply personal process. It's how our body protects us, activates the medicines we need, and clears them when their job is done. Understanding this helps us use medicines more safely and effectively, tailoring treatments to the individual. It's truly a cornerstone of modern medicine. I hope this has made this amazing process a little clearer for you. It's a topic I am so passionate about, and I truly believe that understanding how our bodies work empowers us all. What did you find most interesting? Do you have any questions at all? Please don't be shy. I'd absolutely love to hear from you. Let's chat about it in the comments below. Thank you so much for joining me today, and I'll see you next time.